Have you ever encountered a patient with persistent hypokalemia, rising bicarbonate, and a pH of more than 7.5 despite stopping diuretics? Or an ICU patient whose ventilator weaning became unexpectedly difficult because of metabolic alkalosis? Metabolic alkalosis is often considered a benign acid-base disorder. But severe alkalosis can impair oxygen delivery, reduce cerebral blood flow, precipitate arrhythmias, prolong mechanical ventilation, and increase mortality. In today's video, we'll discuss the pathophysiology, causes, diagnosis, and a practical bedside approach to metabolic alkalosis. What is metabolic alkalosis? Metabolic alkalosis is characterized by primary increase in serum bicarbonate resulting in an elevated blood pH above 7.45. On arterial blood gas, you'll typically find high pH, elevated bicarbonate, appropriate compensatory hypoventilation with increased CO2. Remember, the lungs can only compensate partially. The expected compensation is expected CO2 equals 0.7 times HCO3 minus 24 plus 40 plus or minus 2 millimeters of mercury. If the CO2 is significantly higher or lower than expected, suspect a mixed acid-base disorder. How does metabolic alkalosis develop? For metabolic alkalosis to occur, two events are usually necessary. Step 1. Generation of alkalosis. This happens due to loss of hydrogen ions and gain of bicarbonate. Step 2. Maintenance of alkalosis. Normally, the kidneys rapidly excrete excess bicarbonate. Alkalosis persists only when the kidneys are unable to eliminate bicarbonate because of volume depletion, chloride depletion, hypokalemia, reduced GFR, and excess mineralocorticoid activity. This concept is extremely important because treatment depends mainly on correcting these maintenance factors. The easiest classification is based on urine chloride. First, chloride-responsive metabolic alkalosis. Urine chloride less than 20 millimole per liter. Common causes include vomiting, nasogastric suction, remote diuretic use, post-hypercapnic alkalosis, chloride depletion states. These patients are usually volume depleted. They respond well to normal saline and potassium replacement. Second is chloride-resistant metabolic alkalosis. In this entity, urine chloride is greater than 20 millimole per liter. Common causes include primary hyperaldosteronism, Cushing syndrome, severe hypokalemia, Bartter syndrome, Gittleman syndrome, ongoing loop or thiazide diuretic therapy, and apparent mineralocorticoid excess. These patients generally require treatment of the underlying cause rather than saline alone. Symptoms depend on severity. Mild alkalosis may be asymptomatic. Severe alkalosis can cause confusion, muscle cramps, tetany, paresthesia, seizures, cardiac arrhythmias, reduced coronary blood flow, and decreased cerebral perfusion. In ICU patients, metabolic alkalosis suppresses respiratory drive, causing hypercapnia and difficulty weaning from mechanical ventilation. Diagnostic approach. When you see an elevated bicarbonate, ask yourself 4 questions. Question 1. Is this truly metabolic alkalosis? pH, bicarbonate and CO2 compensation. Question 2. Is it chloride responsive? Measure urine chloride. This is often the single most useful bedside investigation. Less than 20 millimole per liter means saline responsive. More than 20 millimole per liter means saline resistant. Question 3. What is the potassium? Hypokalemia not only accompanies metabolic alkalosis but also perpetuates it. Always correct potassium aggressively. Question 4. Is there mineralocorticoid excess? Verify. Blood pressure, serum renin, serum aldosterone, and medication history. Think of hyperaldosteronism whenever hypertension and hypokalemia coexist. Treatment depends on the underlying cause. For chloride-responsive alkalosis, treatment with normal saline, potassium chloride, stop gastric losses, and adjust diuretics. For chloride-resistant alkalosis, treat the underlying disorder. For hyperaldosteronism, mineralocorticoid receptor antagonists or surgery. Stop offending medications if any, and correct potassium and magnesium. In ICU patients, for persistent metabolic alkalosis despite conventional therapy, options include acetazolamide to promote bicarbonate excretion, dialysis if severe alkalosis coexists with kidney failure, and rarely, intravenous hydrochloric acid in life-threatening alkalemia with pH above approximately 7.55 to 7.60 when conventional therapy fails, administered only in experienced critical care settings with close monitoring. Remember, treat the patient, not just the bicarbonate. Before we finish, here are take-home messages. Metabolic alkalosis requires both generation and maintenance. Urine chloride is the most useful investigation for determining the cause. Correct chloride and potassium before considering exotic diagnoses. Hypokalemia maintains alkalosis and alkalosis worsens hypokalemia, a vicious cycle. In ICU patients, severe alkalosis may delay ventilator weaning and deserves prompt correction. This is the end of this video. In the next video, we'll discuss another interesting topic on acid-base disturbances. If you found this video helpful, please like, subscribe, and share it with your colleagues. Thank you for watching.